Hi, everyone. It's Dr. Tofi. Welcome to Hernia Talk Live, our weekly session. My name is Dr. Shirin Tofi. I am your hernia and laparoscopic surgery specialist. And today we are joined by my dear friend from across another continent, Dr. Hakan Gök. He is a hernia surgery specialist and very involved with the European Hernia Society and the Turkish Hernia Society. He is based out of Istanbul, Turkey, but I get to see him often at all the different meetings. You can follow him on Twitter or X at @hgok. So please welcome, Hakan. How are you?
Thank you. I'm very delighted to be join this YouTube session and the Hernia Talk. Yeah, I'm learning too much from your sessions. Yeah, it's a big endeavor. You know, it's more. You already achieved more than 100 sessions.
Yeah,
it's a big endeavor.
This may be the 150th session, I think, if I counted right.
Too much, you know. Yeah, big endeavor. Congratulations for that.
Thank you so much. You do a lot too. You're very involved with all the different hernia societies and guidelines and their social media. So, I mean, you're very busy and influential as well. So I learned from all my friends, including you.
Me too. Thank you.
So when I approached you to say, would you be my guest? Your offering was, let's talk about questions that patients should ask their surgeons. And I thought that was great. Most people say, oh, we're going to talk about this surgery or that surgery. But I love that your interest was patient-centric.
Yeah, because, you know, we discussed the priorities of the patients and the surgeons are very different. We should look at the diseases from patients' perspective, from their expectations. We should consider in our decisions. We should include them to the decision-making process, such as watchful waiting, and we should discuss the technique or surgery or things together, and we should make decision together with the patients. So recently, you know, we also do. There is a ongoing important things, the patient-reported outcomes that we generally use generic ones that just ask the question the patient's quality of life, but they are not enough. So maybe we discuss later, but they should also include the disease-specific patient-reported outcome uses should be considered for hernia-specific or other diseases or the colorectal or. You know,
it's a lot of work because the quality of life questionnaires that are out there have been validated for thousands of patients over years. We do have some hernia related questionnaires, but they haven't been validated as strongly as the just the standard quality of life questionnaires have been. But you're absolutely right. So, you know, what's interesting is usually when we talk about, getting the patient involved and patient rights, it's usually something that's very strong in the United States. That's something that so much of our kind of policies and so on are geared toward it. But the European Hernia Society seems to be leading a lot of the ways. You all have a whole section of your meeting dedicated towards patients. You have patient advocates coming to your meetings. You have, I think, a committee, right?
Recently we established a patient advisory committee under the general secretary. So Jackie Block, she's a good friend of us. She's hernia friends from UK. She's in the group.
She's actually watching you right now. So she's watching right now.
Yeah. Hi, Jackie.
Yeah.
Next week we will meet in Prague with her.
Yes.
So
Prague. I'll be there.
So she's doing a very great job. You know, she's very busy with that. So she's also managing the hernia patient support group. So this group is, last year we established, founded the group. So there are more than 3,000 hernia patients there. We are hernia surgeons there in the group, but we are not involved too much, but we learn too much from the patients. They are discussing their problems, and it's more education for the surgeons, but we are just observing, you know.
Yeah, I completely agree. It's so important. The whole concept of including the patient, you know, I'll give you my experience. I do this every week almost. And there are certain surgeons that are very uncomfortable talking like we're talking when there's a patient audience. And part of the reason seems to be that they, like, if I say something to a doctor, it may actually be rude or disrespectful if a patient's listening, you know, talking about obesity, talking about failures, hernia failures. These are words that we use that we don't consider it to be weird. But if you talk to a patient about a failure, that's a much different sentiment than, you know, what we talk about hernia failures all the time. It's not like we're not like making a judgment call. So the language that we use, the words that we use often amongst ourselves is maybe not appropriately translatable to a patient population. So I've learned that it's very important to kind of make that balance. But some surgeons are very uncomfortable because they feel that they're not as comfortable saying what they'd like to say when they're being scrutinized. Maybe they feel they're being scrutinized by a patient population. I mean, we are being scrutinized. I think every week I'm being scrutinized. So that's not bad. You know, I need to be aware of the needs of my patients. What do you think about that?
Yeah, we should change, you know, the patient is in the center. We should focus on, we should listen to them. So we should understand their sufferings, their complaints. So, you know, hernia surgery is, we always say that it's a tailored surgery. So it's not to all. There are different variables such as the patient's comorbidities, physical features, and the features of the hernia, the type of hernia, size, or anything else, the location. So also we have the surgeon factor. So surgeon's expertise. So it's, you know, capabilities of to do that kind of surgery, and then what type of hernia repairs he has or she has in her armamentarium. So many, it's a complex disease, you know, so many variables. So if you focus in the one subspecialty such as hernia surgery and abdominal wall surgery, so we see and we observe that the good outcomes with the patients.
So I'm curious about your take on this, because what I maybe would like patients in the United States to ask their surgeons, I don't know if that's the same is true in Turkey. So I'll give you an example. I'm okay with patients, and I encourage patients to see multiple doctors. I don't take it personally that they've seen a second opinion. I think that's a good thing. I encourage that. And then I have patients that come and some patients come with like pages and pages of questions. And I allowed time for that. Most people in the United States that practice don't have an hour and a half to spend with a patient. It's 10, 15, 20, 30 minutes. So they get put off by a person who shows up with a book of questions. I get a lot of questions on Instagram and YouTube, and, you know, people go on Facebook and they direct message me with questions. The Europeans or the Americans, they'll send me like 2 pages of their history on just a direct message. But like people from the Middle East, they will say, thank you for your time. I hope I'm not bothering you. May I ask you a question? And that's it. And they expect me to respond back with yes or no before they send their question, whereas the American will send me 2 pages of their history without even an introduction. So in Turkey, what is it like?
Yeah, it's across the pond. It's different. So, they don't ask too much, but before they come to you, so I'm running a private business. Before they come to you, they look at search on social media.
Mm-hmm.
So they look at your social media presence. So because it's like not internal medicine or something that we will prescribe something and they will send to the home. We will do surgery, we will operate them, they will get anesthesia, they will sleep. It's a serious process. So but they don't ask but for my inguinal hernia patients, I talk around 1 hour, but incision hernias are very complex, so I probably more around 2 hours. I
Wow.
explain everything. Yeah, I separate them. It's because they are very important patients. So processes, they should know in every details. So I sometimes I tell them, well, yeah, I think I said able to think about your condition and the disease. But if you remember something later, you could take notes and come again. We discuss on it. I will reply them. So, but they don't ask too much in my country because, but that conversation, you get their trust. It's very important. You should give time for them. It's very important. Every patient deserves this.
Yeah, I agree. I think they need to have your trust, and the openness to be able to answer their questions is an important part of the trust. I also do the same. At the end, I say, if you have any more questions, feel free to call us or email. I work well with email. Almost no one does. It's not like I'm bombarded with every single patient coming back with questions, but I think that helps, and it helps gain patients' trust and understand that you're not there to just operate, or not consider their situation.
Yeah, I don't have such a big, patient list, so I'm not working in the public. So every patient, they get my private phone number. Anytime they can.
Oh, wow.
But they are very kind. They don't call like
I should have put your number down instead of your Twitter page. Your Twitter.
Yeah, also Twitter, Twitter or X is,
X.
changing the policy X. So changing the policy, it will be a new communication tool for the people, email, video conference or something.
Yeah.
So
there's
so.
So what are your thoughts about questions patients should ask? I feel that last week we talked about this a lot, which was patients do a lot of research and then they get really stressed out and they feel like they personally need to figure everything else out on their own. And I say, no, like do your research, understand, mesh, laparoscopic, etc., all these things, but then you should go in, talk it over with your surgeon and have them feed you the information. Patients on HerniaTalk.com literally are stressing over the very details that you and I think of already, but I don't expect a patient to think about it. So do you want patients to come to you somewhat well-read and then you kind of ask questions? I have patients that come and they tell me what they want. Hi, I came here for a shoulder hernia repair, and now they have this huge scrotal hernia that's recurrent. And I'm like, I'm not going to offer you shoulder. And they're like, I drove 2 days just for you to do a shoulder ice. And I tell them, maybe that wasn't what I would offer them. So what do you expect of your patients?
So in general perspective, most patients, they don't aware that a mesh use it to reinforce the in the repair in the hernia area. So yeah, so we should inform them about we will place a meshed area. So we should also, yeah, we should also mention about the complications, including the mesh and, you know, pain issues or something. But, you know, in steps, first they should ask the diagnosis. What's the diagnosis, treatment methods. They should also sometimes ask that there is any treatment without surgery. You know, the hernia surgery,
Yeah.
the only cure is the surgery. But they asked if they don't get the surgery, what happens? You know, we have watchful waiting in inguinal hernia surgery, so it's, you know, trustable. But in my opinion, in incision hernia, I don't vote for the watchful waiting. You know, for incision hernia, they should be, as soon as possible, they should be operated. You know, they will not stop in same time. They will get bigger in time. So incision hernia should be done early. But and the other aspects, they should, the patient asks the complications, outcomes. They are curious about how they will, when they will discharge from the hospital, when they will go into the daily life, and when they will drive. Even they ask the impact on sexual activity. You know, it's so obvious. So but they don't ask our expertise. You know, it's very important. You know, we are general surgeons. We are treating the hernia patients.
Yeah.
But we also do the other surgery. Not me. I'm only doing the abdominal hernia surgery. But they should ask the expertise or related questions, such as when the surgeon went to do any hernia congress recently, they could ask that. You know,
That's a good point.
If you're an academic surgeon, they could ask the publications. You know, are the surgeons are a member of any hernia society? There are many hernia societies, country societies, clubs, European Hernia Society. So they could also be, you know, European Hernia Society is publishing hernia guidelines. So I always mention the patient that I always mention from the guidelines in inguinal hernia or the vertebral hernia. So it's because the top knowledge on the hernia surgery, you know, guidelines very important. I always mention and I make my decision on that guidance. So there is a saying that I do inguinal hernia like this way. There is no self-surgery. It's already determining technique for hernias. There is a name, Liechtenstein, Bassini, Schuldeis, or, you know, TEP, TAPP. There is no other technique actually. So
yeah, I think that what you started to say from the very beginning was very important. Just because they're seeing a surgeon doesn't mean they should have surgery. And so I always like it when patients say, well, do I need to have surgery? And I'm like, oh, thank you for asking. That's a great point, because there is data in support of watchful waiting for primary inguinal hernias and small umbilical hernias, not incisional hernias, not recurrent hernias. We don't have that data. And then, you know, what's good, people ask me, like, how old are you? I tell them, you know, my age. I don't care that people know my age. But I think more importantly is, how long have you been in practice? That's good to know. You know, you don't want someone the first 2 to 3 years of practice, probably. If you want an expert, that would not be the person. And then, yeah, I do tell them exactly what you said. Like, have they been to a meeting lately? Like, if they publish, that usually implies there's some critical thinking and interest in asking questions and getting to learn. If they talk or give presentations, usually that implies that they're knowledgeable, not necessarily, but that they are knowledgeable about the topic. Doesn't mean they're a good surgeon still, but and then what's your definition of a hernia specialist? That's one thing people are like, how do I know if my doctor's a hernia specialist?
Well, it's a tough question,
Yeah.
But hernia specialist is not just doing the hernia surgery. They could also do the other surgery, but following the current progress, to developments, to published literature. So also it's a community doctor or rural one. Even they can publish. They can publish. They can go to the congresses. They can present their experiences. Also, they are. If you in the previous session you made it talk with Maciek Pawlak.
Yes.
And I joined the session, if you promote yourself as the hernia surgeon, so you get more complicated cases.
Yes.
You don't have primary cases. Because people also, other surgeons refer to the complex cases to you. So you also deal with that kind of complex patients. So it's, it's a route to become a hernia specialist, but it's not easy to, even in the hernia surgery, to progress in the world, Do
you think, I always say, I always say, if at least 50% of your practice is hernia, then at least that shows you have some special interest in hernias.
But it's not enough.
But it's not enough to be a specialist.
For example, it's a big issue is the chronic pain. You should deal with the chronic. You should treat the chronic pain. If you don't treat the chronic pain issue, it's a huge amount of patients out there. So if you don't deal with them, so you should, you should think I'm a hernia surgeon.
That's 99.9%. Don't do chronic pain.
And last week in Istanbul, I'm currently in Madrid.
Yeah. By the way, to the audience, Dr. Gök, who lives in Turkey, is currently in Madrid. Do you want to explain why you're in Madrid?
So, as you know, it's a long story, but in short, I brought a patient of me because he has a big complex incisional hernia. He has a kidney transplant hernia, so he has COPD and complex case. There's a center here in Madrid. They are my friend Miguel and Javier.
Yeah.
So we decided to because the surgery it's also in hernia. The surgery starts before the surgery.
Yes.
Rehabilitation. Yeah, I did Botox the patient in Istanbul. So he has uncontrolled diabetes. We tried to fix the diabetes with the Ozempic, and we had success.
Oh.
So he came here. So they did PPP, progressive pneumoperitoneum, to make room for their organs outside of the abdominal cavity.
Yeah, they inject air in the belly to
every day. Yeah, every day we inject air. So yesterday we did the surgery. It all went well. So he's in IC now. He's stable. So we're gonna see. So he will come later after me because I'm going to back Istanbul next Friday. The other flights, I was coming to the Austin for the AHS, American Hernia Society Congress.
Yes.
Last week in Istanbul, in Robotic surgery collaboration meeting, I spoke to the audience, and Eduardo Bassini, Italian surgeon, is the father of hernia surgery.
Yeah.
So I made a diagram in my talk, and I said that how Eduardo Bassini and my name be mentioned in the same sentence. So, and then I said that I became a surgeon a century after Eduardo Bassini. So I made the same sentence. So I always say my patient, my expertise is almost 30 years. I'm in the surgery. Yeah, I'm very, in the beginning, I'm very interested with the hernia surgery. I can say another story. When I was younger surgeon, a patient came to me in 1997. I remember well. The internet was new. I had new laptop, and the patient came recurrent inguinal hernia. So I made a search on internet. There was no Google that time, just Alta Vista, Yahoo,
Oh, yes. Yeah.
search engines. So I saw that in America, there's Ethicon site. There is a new mesh released. Its name is PHS,
Yes.
bilayer mesh. So they say there is an advertisement on the site. So it's saying that we could send you brochure, flyer. We could send you the product. Also, we could send you the surgeon. Wow, surgeon. It's writing surgeon. The surgeon is coming. We are doing the surgery together. It was amazing that time for me. So, but I couldn't ask a surgeon because I was living in Turkey. So I just requested a flyer and the product. The day after, the distributor of Ethicon in Istanbul, they came to me. They visited me. You see that at the speed. So it's very interesting. So it's hernia surgery also. It's very interesting because abdominal wall. We do the abdominal wall surgery. The abdominal wall is the organ actually. There is not such the skin, fat, or muscles. The layers. It's a complex organ. So if you look at it, it has width, it has length, but it's the thickness is not that. It's like two-dimensional organ. So in every hernia repair, in even open, in laparoscopic, robotic, we do it, we open it, we do it 3-dimensional. Then we make our repair, suture the hernia area, we place the mesh, and return it to the 2-dimension. It's magical, actually. It's complex, different angles. So I like that kind of surgery. So I'm a fan of it.
Yeah, that's really fascinating. There's some questions that are being asked from the audience. I'll ask them to you. So should you ask your surgeon prior to surgery how they would manage a complication, let's say with pain, chronic pain, if it occurs, and whether they can manage it themselves or refer to someone else? I think that's a good question.
Yeah, it's a good question. We don't expect if properly performed hernia surgery. I'm talking about the inguinal hernia, but we don't see much chronic pain in the anterior abdominal wall. So if it's properly performed, even open, even laparoscopic, we don't see much pain. But I always warn surgeons that if immediate after the surgery, if you see the high level of the pain, then there is something wrong. So you should take back to the OR the patient. So you should check what did you. So it's important. So to avoid chronic pain, laparoscopic surgery is recommended to minimal invasive techniques. So robotic surgery as well. So because in inguinal hernia repair is basically in the open surgery, we see the three important nerves, the sensory nerves. So we protect them, we preserve them, we observe them, we become very careful to care them. They come to the groin between the muscles from the side. But in laparoscopic surgery, we are behind the muscles, so we don't see them. But we can risk that nerves by fixating the mesh or suturing or wrong dissections in the area. But if you look at from publications and data, yeah, less chronic pain with the laparoscopic repairs.
You saw on herniatalk.com, there was a post, what is the least painful hernia repair for inguinals? And, I would very quickly say laparoscopic, but as the discussion online is that there are a lot of people on the site that underwent laparoscopic surgery and had complications.
Sure.
I do get those questions like, you're gonna put mesh in me, what if can you remove the mesh afterwards? And so I do mesh removals, but I guess that if you ask that of a surgeon and the question is like, the answer is, oh no, you can't remove the mesh afterwards, or I can't do it, does that necessarily mean that they shouldn't be with that surgeon?
To remove the mesh for the surgeon, that kind of issues should be referred to the referral centers, of the experts hernia surgeons, because it's like changing a part of the car and replacing with the new one. It's when we place the mesh, it's very integrated with the body. It's inflammation, so severe adhesions in the area. It's not easy to remove a mesh. It's very complicated situation. So to mesh removal, the decision is very important. If we are really sure that the mesh removal will have help to the patient, we try it. But it's better to send some complicated case to the referral centers, to the experienced ones.
But do you think the patient should not go to a surgeon if they are not going to be able to handle the complication? Or what are your thoughts on that?
No, if we do the surgery, any kind of surgery, including the hernia surgery, so we are capable to deal with the complications. So there is not a question point that also it shouldn't be asked to a surgeon, I guess. Sure, the surgeon can handle the complications because.
Yeah, I would say a true hernia specialist would be someone who can handle complications, right? That's what makes you a specialist. But there are perfectly good hernia surgeons that are very good quality in terms of their surgical technique and what they do, and hopefully they understand what a complication is so they can refer it out. But I don't think every single patient is going to be able to find a surgeon that is a specialist that also does complications. In other words, it shouldn't be an automatic no if your surgeon says, oh, I've never removed mesh, or I don't know how to remove mesh. But if they say, oh yes, I understand that is a complication, I'll refer them to so-and-so, then that's okay. If the surgeon completely says, oh, I never have complications, I never need my mesh is removed, I've never had a patient that needs another operation, that is not a good sign usually, right?
Yeah, there is no word like that.
Yeah, there's no such thing.
Yeah, there's nothing that, so it's.
But I would say just because the surgeon themselves cannot handle a complication doesn't mean they're not a good surgeon. Does that make sense? They're not true specialists. They just need to identify when you need a specialist that can handle, let's say, mesh removal or injections or whatever the chronic pain needs are. But doesn't just because they themselves don't do it is not necessarily an exclusion.
Yeah, the chronic pain is a complication. It needs multidisciplinary approach. So
yeah,
it's better in such circumstances. It's better to if you are not a hernia surgeon, it's a general surgeon. I see that they can not capable to follow the progress, the pathways to deal with the chronic pain. Yeah, that's why we need referral centers of complex chronic pain cases, So,
But I think the
you know,
question that was being asked, I think the gist of it is, it's good to talk to your surgeon about how they would handle complications. Like,
yeah,
are they thinking what's plan B, right? Plan A is this, well, what's plan B? Because that determines, they may have to change their plan during surgery even. So if they have the forethought and the experience to do that, that's a good sign. If they deny that there's ever any need to change or any complications, then that maybe is a sign that that's not the right surgeon because they
yeah,
don't understand hernias.
yeah, I agree.
Okay.
For example, we should if you do minimal invasive surgery, such as you do robotic hernia repairs.
Mhm.
I don't have any access yet, but mostly I will do soon.
Yes.
And I do laparoscopic surgery that, there is a risk of conversion to open due to complications, or even without complication, we can convert to the open surgery.
Yeah.
This should be also informed to patient, because it shouldn't be a surprise for the patient, because they see a cut in the area. It's surprising, and they will not be happy after when they see. So if you
Yeah.
say before the surgery, the risk is less, but we should mention about it.
Yeah. Yeah. Agreed. How do you talk to your patients about mesh? Do you give them any handouts? Do you tell them pros and cons? Do you offer them non-mesh if it's possible?
Yeah. So I talk about the mesh. I also give, it's very important to use, quality, the quality of the mesh is important,
Yes.
I prefer so a surgeon should know detailed about the mesh technology and mesh science. It's a science.
Yes.
So recently, FDA released a paper for the mesh on its website.
Information
It's a
sheet.
very good booklet and informative. So I have foreign patients coming from abroad for hernia repair. So
Yes.
when I chat them, I share the link for their information. That's very detailed. So American Hernia Society they published a mesh paper in 2018. Also, British Hernia Society did. So hopefully we will do in European Hernia Society similar things. So it's not the mesh for the pain. So that there's a saying that mesh injured patient,
Yes.
it's a misnomer actually. So,
Mhm.
hernia surgery injured patient is more proper for using, because
What's the more
if
proper name?
hernia surgery injured patient.
Hernia surgery injured. Yeah.
Injured. Yeah, because it happens after the hernia surgery. There is, it's variable reasons for the complications, such
Yeah.
as nerve cut for the pain or inflammation in the tissue,
Yeah.
so infection, recurrence. So we shouldn't blame in every case the mesh.
Yeah. No, that's true. A lot of people have recurrence, they blame the mesh. I'm like, that's not a mesh problem. I have the survey. I highly recommend you send it to any patient groups you belong to. But it's to learn more about mesh Asia syndrome, or kind of implant reactions, whether it's breast
Yes.
implant or mesh implants. And a lot of people, you can have pain, but to actually react to a product is usually not painful. It's not painful in the area. It's usually like hair loss and joint pains and chronic fatigue and rashes, as opposed to, I have groin pain after my hernia repair. That's not technically a common reaction. It's the way we think about like autoimmune reactions to meshes. So people, interpret mesh problems differently. In the United States, we have so many lawyers and lawsuits, and they are all basically putting everything under one umbrella. Recurrences, infections, fistulas, chronic pain, everything is a mesh, even nerve pain may not be related to the nerve. As what did you say? It's the Indian, not the arrow.
Yeah.
Yeah, so it's the surgeon. A lot of the complications are related to the surgeon, not necessarily to the mesh or the product itself, but it's a technique issue.
It's one foot of the process. The surgeon is very important.
Yeah.
So it's difficult to do surgery in the United States. I saw some advertisement from the law offices that if you had any complications in any surgery or such, so come us, we help you like that.
Yeah, that was my talk at the EH.
They are advertising. It's not good.
Yeah, lots of advertising. So, Turkey is becoming very famous for medical tourism, hair transplants, plastic surgery. Do they come to you also for hernias?
Yeah, they come from, that if you look at we are mostly the patients coming to the Europe, to the Middle East, the Gulf area from the East, because there is a huge amount of wait list in the UK, in the Europe, because of healthcare professionals shortage. So, for example, last year it was 6 million wait list for the surgery in any kind of surgery in the UK. Last month I watched the British Prime Minister Sunak in the Parliament. The opponents asked him when he came to the office, the wait list was 7 million in the UK. In the 6 months, he replied them, it's now 7.5 million patients waiting any kind of surgery. So it included hernia surgery, hemorrhoid or nose or breast. Yeah, they are helpless. So people try to find a solution. They go abroad. So we mostly attract the people for the plastic surgery, dental surgery, hair transplants. So we have our Turkish Airlines goes everywhere in the world.
Yes, Turkish Airlines for sure.
Yeah, direct everywhere it goes to the directly, so it's easy. It's comparable prices. So there is also recently a change in our currency rates. Our economy is big, so we have good prices for health tourism. But we have good infrastructure. There's very high quality A+ hospitals in Istanbul. So we can do the surgery immediately. There is no wait. In my practice, I don't like the patients see the first in the day of surgery. So I ask them come 1 day before.
Yeah.
I talk them, I examine, consult them, and I make the surgery before. So I also send some questions, surveys to assess his situation for the general health status as well as the hernia.
Yeah.
So I don't want to have a surprise. For example, they could use, blood thinner or some things. So I should be aware before they come to Istanbul, Turkey.
Right.
So, but the problem is on the quality of the surgeries, of the treatment. There is it's economic. It's a business, so they
Yeah.
make packages too. So, for example, they make a 4-day package for the bariatric surgery. Yeah, you know, after 3 days after the surgery, they are going back to home country with plane. Yeah, it's not, you know, it's bariatric surgery. It's very complicated surgery. You know, they should stay more. But you know, there is a market on it.
Yeah.
It's not
Yeah,
good.
the packages. I've heard about the packages. Okay, here's a good
Yeah.
question. So this patient sounds like they have chronic pain after their hernia repair. They went back to their surgeon. They did some nerve injections. They had MRIs. They had suture site injections. Nothing seemed to help. There's no consensus as to why they have the pain. And so no surgical option was provided. And then the patient was sent to pain management for spinal cord stimulator. What's your reaction to that?
Yeah, actually, it's important to distinguish the origin of pain. Is it neuropathic origin or non-neuropathic? If it's neuropathic origin, yeah, I bypass the you know, that kind of is complicated interventions performed by the algologist. So pain spaces. So I prefer to go to the, you know, neurectomy way.
Yeah.
It's proven, you know, already. So good outcomes with the neurectomies. So yeah, hopefully we have too much open cases. So we see much chronic pain in the open cases. So in laparoscopic surgery, if chronic pain, neuropathic origin, it's very complicated to, you know, proximal neurectomy, triple neurectomy it has side effects such as bulging. It's an important issue. So
I personally, I'm not a fan of the spinal cord stimulator until
yeah, me too.
everything is completely ruled out. And for most patients with hernias, unless you've had all the nerves cut or and the mesh removed, there's no indication for a spinal cord stimulator because there's a lot of need for
it's not selective as well. It's not selective.
yeah. So I would tell this patient to seek a second opinion from a real hernia specialist. You know, they can call me for the office, you can go to Cleveland Clinic. A lot of the patients, a lot of the people that I've interviewed on HerniaTalk Live, specifically about chronic pain, those would be a good option to see before you commit to spinal cord stimulator, because spinal cord stimulator doesn't cure you of anything. It just treats your pain and only treats really nerve pain. It doesn't really treat, you know, hernia recurrence.
Yeah, also
or meschoma.
I see some patients coming with the ejaculation pain. This ejaculation, yeah, it's also, you know, it's hidden under the chronic pain,
spinal
but
cord
it's
stimulator
another, yeah, it's another part of the, you know, chronic pain. There is also, you know, the urologists are not aware of that origin of pain after the hernia repair. So I do sometimes in you know, core vast generation. So you know, scar excision, or sometimes do hybrid operations, do laparoscopic proximal cut of the genital femoral nerve as well. Yeah. It's a combination of surgery, you know.
Yeah, some people they've had a hernia repair and then they have urologic symptoms like testicular pain or ejaculatory pain with intercourse, and they're sent to the urologist. I've had patients have their testicles removed. I've seen them have spermatic cord denervation procedures, epididymectomy, all these things, and what they had was, let's say, a hernia that could have been fixed, or they had some mesh related complication. So I work with urologists that understand mesh and hernias, and what happens upstream can cause problems downstream, but there aren't that many urologists that work with general surgeons that way.
basically, the nerves are sensory that goes to the inguinal region. That does not innervate the testis.
Right.
Testicle has different innervation. It's somatosensory innervation is very different. So it has some roots from the pudendal nerve. It's also innervates the autonomous nerve plexus, has innervated the testicles. So
That's the vas.
it's
There are
very different.
nerves
Yeah,
around
it's
the
very different.
but there are nerves around the vas that can be injured from mesh or
Yeah,
manipulation by
sure.
surgery that can
So I
cause
do.
testicular pain. Yeah.
Sure.
And then, so do you think it's appropriate for a patient to kind of come up with a plan first and show up, or should they have an idea of like what they think they need before they go in to the surgeon?
So if you mean that the patient indicate his or her repair to me and I apply to the patient.
Mhm.
Yeah, if it's not, I don't do that actually. So if it's not a good decision for the patient, I reject. I sometimes reject the patient.
Yeah. I feel the
You know,
patient stress like they have to know everything before they come to the
yeah, but
office. Otherwise,
if
they'll get wrong
yeah,
information or something.
for example, if they prefer they don't need any mesh,
Yeah.
so I do tissue repair, but I inform about a slightly increased risk of recurrence rate and the chronic pain. So the mesh does itself not the reason of the chronic pain in most
Yes.
instances. So some patients don't want general anesthesia because the minimum invasive surgery requires general anesthesia.
Yeah.
And I don't like apply the spinal anesthesia. I don't like actually. It's because
Seems
of the
too invasive.
complications. Yeah. So I do local anesthesia, hernia repairs, Liechtenstein, mesh repairs, and tissue repairs. It's in
Yeah.
most in cases. So in elderly patients, I also prefer the open surgery in some
Yeah.
instances because there is this saying that in some people with mentally problems
Dementia.
started due to
Prone.
the
Yeah.
dementia or Alzheimer. So anesthesia may speed that.
Yeah.
So I do the local anesthesia, but in step by step. First, I block the nerves with the ultrasound guided local anesthesia. I do ultrasound myself and go step by step. It's always successful.
Yeah.
It's a day case surgery.
Yeah, I completely agree. So how do patients find you? Do they or contact you for a consult? Can someone from the United States come see you or even talk to you before seeing you, or how do you?
The complex ones is coming from other surgeons they are referring, or they find me through the internet.
Mhm.
In some cases, comes from the my patients they
Yeah.
refer. So from some people coming from Google. I have websites.
Oh, really?
Really, yeah, they come. So there is, but if you facilitate, if you facilitate the connection easily, such as we have a WhatsApp line, so they can easily text me, they can share the pictures and images, so it's easy to go,
Wow.
conversation.
That's really great. And what's the way? Oh, here's a question. Let me ask. Oh, this is a very specific question. Can the genital nerve and pudendal nerves be blocked under ultrasound guidance? I have been told you need CT fluoroscopy with radiation exposure. Yeah, of course you can do ultrasound guidance. I do genital nerve blocks with ultrasound guidance all the time.
But the pudendal nerve is very low. I don't know. It's not in our region actually. It's probably going out from the L4, S1. Pudendal
It's
nerve.
sacral, yeah. So for
Yeah.
pudendal nerve, there's a posterior
Too low.
approach. Yeah, there's a posterior approach and anterior approach. I don't do pudendal nerve blocks, but urologists tend to do it from anteriorly, and I don't think they use, maybe they use ultrasound. And then posteriorly, pain doctors can do it. They don't use CT fluoroscopy at all. They use they may use fluoroscopy, but they also use ultrasound, or they do it anatomically based on.
I do diagnostic block to genital nerve from both from proximal to the in the inguinal region. So, but just for the diagnosis temporarily. So I don't do any permanent block with injection.
Like
So
ablation.
I prefer surgery. I prefer surgery.
Yeah, there's no good study to show that
The permanent block that doesn't.
ablation or any of those have any better or worse outcome than surgical neurectomy. I try to look for it because we published our study on neurectomy to see the neuroma rate. We found if you prophylactically cut a nerve, the neuroma rate in our study was 0%. But if you have a pain issue like a neuroma, yeah, then your risk of neuroma again is about 4%.
Yeah.
So I don't know if it's lower with ablation. I don't know. There's no study that shows what that rate is.
Yeah.
Someone needs to do that study.
Mhm.
So you're coming to Austin? Will I see you in Austin for the American Hernia Society meeting?
Yeah.
Oh,
I'm coming
great.
on Wednesday. Yeah.
Yeah, me too. I'll be there Wednesday to Sunday.
So there is something to see there. It's not like Barcelona, but you should
I don't know.
investigate.
Maybe our audience can tell us what to do in Austin.
Yeah, you're gonna see that.
It's in September, so it's going to be hot still.
Really?
And Texas,
Yeah, it's Texas. Yeah.
Texas hot is no joke. And they have mosquitoes.
You know, on Sunday I came to Madrid. It was in Istanbul. It was hot. You know, it's also in Madrid. It was raining when I landed here, and when I opened my phone, I got a alert message from the information that says it's the flood alert in Madrid because of the heavy rain.
Oh wow!
Yeah. Oh, interesting. Now it's good. Yeah.
Okay, good. There's been floods all over the world, it seems.
Yeah.
Okay, well, I look forward to seeing you in person again.
Yeah. Me too.
We hung out at the European Hernia Society meeting in Barcelona, so that was very cool.
Yeah.
Enjoyed that. Although I'm told that the other cities in Spain are much nicer than Barcelona. Is that true?
No, Barcelona is better.
Oh, Barcelona.
Yeah, Madrid is good, but you know, I visited 2 museums here, Reina Sofia. I'm very interested with the Picasso, Miro,
yeah.
and you know, yeah, in Madrid, I visited Reina Sofia and the Museum Thyssen.
Mm-hmm.
There were huge amount of Picasso and you know Miro. It's like too much, you know. If you compare to the Picasso Museum in Barcelona, it's much like from here, you know. It's here is better in Madrid.
Yeah.
So last one I didn't visit yet is in Malaga, where Picasso was born.
Oh yes.
Oh, probably it will be next year.
Malaga next time. That will be the vacation. Yeah. Malaga's vacation, not work.
Good place.
Okay, any final comments about what patients should ask in their initial consultation when they show up? They should show up with questions, right? And concerns, I think.
You know, in short, if they ask the surgeon's expertise on the topics, so it probably covers all about the other things. So the patients should ask their surgeons to have time to discuss everything, the most important things before so to know everything before the surgery is very important.
That's true. So in
For the
summary,
mentally and the physically.
they should let the office know they have questions. They should come with questions like written down.
Yeah, they should
They should-
prepare before to come.
They should ask if there's non-surgical options. They should ask about surgical technique and outcomes and kind of expected recovery. I also tell them what to do between now and surgery, in terms of pain control or activities,
Yeah.
that kind of stuff. And I think it's important to know how much of the surgeon's practice is dedicated to hernias and even hernia complications, because that gives you a little bit of an idea as to how much they enjoy hernias, as opposed to it being part of their general
So true.
practice. Yeah.
Yeah, totally agree with that.
Okay, well, that was very fun. This was a great session with my friend Hakan, Dr.
Thank
Gök
you.
from Istanbul. I hope to come to your country. I know I'm giving a talk in November because I can't make it to Istanbul this year, but
Yeah, you
Sure.
missed this time.
I
So many.
know
Yeah,
I need to
you
plan
know
it ahead
that
of time.
Yuri, Konrad, and
David,
David, yeah, they are coming together. They will stay one day in Istanbul. We are
Okay.
together. We will hang out there.
yes,
You missed that. Yes.
I need
Bosphorus
to.
tour and the Grand Bazaar tour. Two topics there.
I need to plan it ahead of time so I can make time. Too
Next
much
time.
travel. Yes. So that's it for us on Hernia Talk Live. Thank you to everyone for joining us. It was wonderful. As you know, you can watch this again on my Facebook page, but also on my YouTube channel at Hernia Doc, where this and all prior sessions are listed. So please do subscribe to my channel. And as you may have heard, I have a podcast now. So Hernia Talk Live is also a podcast. So if you prefer the podcast kind of way of listening, do subscribe there, and that's available on Apple Podcasts, Spotify, and all the other ones. See you all next week. It's going to be a great one. Again, thanks for everyone for showing up and participating, and I'll see you next week. And thanks, Dr. Gok. Appreciate it.
Right. Thank you very much for having me there. Bye.
Bye.